All right, hello and welcome to today's Tuesday topic. I'm Maura Nitka. I am a professor in the nursing program here in the College of Nursing and Health Professions at Drexel University. My background includes I'm a pediatric nurse for the past 25 years, and I've been teaching at Drexel since 2009, so just about 10 years now. And I have gotten very interested in interprofessional education. And this discussion today is going to be on improving professional appreciation through interprofessional partnerships. So we can get started. I have no disclosures to identify. And today I'm talking, but I do work with a team of people. Marianne Godshaw has been very, very supportive from the nursing program. I work with the PA program across many people, and a lot of their students do partner with me for this particular exemplar that I'm going to present today, which is a pediatric palliative care simulation. And I have a few students here with me today who are going to participate in a panel discussion at the end, because I can stand here and tell you why interprofessional education is important and how we went through it and all the things that we have learned, but the power is really with the student and what they get from it and if it's meaningful to them and how they can really translate it to their practice. I also work with a lot of people in the sim lab because my interprofessional activity is a simulation experience. So I not only work within the college here in the Parkway building, but I work with the folks in the sim lab pretty closely when we're preparing the simulation and executing it as well. So just a little introduction to this series. This Tuesday topic is part of a year-long series that's meant to illustrate how the core competencies of interprofessional education and collaborative practice are integrated into our curriculum currently. So over the past couple of months, since I guess at the beginning of the year, maybe the end of last year, we have had different topics related to the 4 core competencies set forth by the IPER collaboration. And in January and February, or January, I guess we focused on values and ethics when Rocky and Ebony and Juanita came and talked about team steps, and Kim Montgomery and her team came and they talked about the 13 interprofessional competency videos that they have that can be immediately implemented into anyone's program so that their students could learn about interprofessional education, communication, and collaboration. I guess it was 2 weeks ago now, Adrian and Laura and I spoke about roles and responsibilities with our discussion, and then this will be the end of the roles and responsibilities sort of focus as we look at the exemplar of the palliative care simulation. All right. So I have a couple objectives. We're going to talk about interprofessional education and collaborative practice. We'll describe the mechanisms of interprofessional education, execution through exemplars, which is the pediatric palliative care simulation, and discuss a student's perspective of interprofessional education and collaborative practice. So we have 3 of them here with us. So one's online from North Carolina. She's doing her clinical placement down there in behavioral health. Is that what Rebecca said? All right, so I think sometimes it's important to know what we're talking about when we talk about interprofessional education and collaborative practice. And it's funny, it came up in a meeting today. We sort of defined what we meant by interprofessional education compared to some of the other terminologies. So there's a lot of different definitions, and they do all relatively say the same thing. However, the World Health Organization really, their definition sort of sets the standard for what we define interprofessional education as. And it's when students from 2 or more professions learn about, from, and with each other to enable effective collaboration and improve health outcomes. Collaborative practice, sometimes these terms are used simultaneously, is when multiple health workers from different backgrounds work together with patients, families, caregivers, and communities to deliver highest quality care. Because our goal is always to improve health and really to improve the health of populations. And how can we as a team, as a community of healthcare workers and other professionals as well, do this really well. Additional terms, when you look at some of the literature and you sort of engage in different educational practices, you know, we might think, yes, we're doing interprofessional education, but sometimes it is more multi-professional or multidisciplinary if you're in the clinical setting. Because interprofessional education, the crucial difference really is that interaction. And in clinical practice, it's the shared collaboration and decision-making that happens for it to truly be interprofessional, as opposed to multidisciplinary, where you might have a PA talk to a nurse and then someone else talk to a social worker, right? Yeah, you're multidisciplinary on the team, but you're not, maybe not sharing the decision-making capabilities and improving the care plan ultimately at the end for the patient. I spoke about the domains or the competencies. So about 10 years ago, a group of professionals got together and decided that interprofessional education and collaborative practice was really important. We were seeing better patient outcomes when people talked to each other, collaborated with each other, and came up with a plan. Health was improved ultimately. So it was really important to those sort of founding fathers. There were 6 professions, included nursing, medicine, dentistry, and a couple others. I'm sorry, I'll tell you. I wrote it down because I knew I would forget. Dentistry, nursing, medicine, osteopathic medicine, pharmacy, and public health. Since the original competencies, and these are the 4, they felt values and ethics were important, roles and responsibilities, teams and teamwork, and communication or collaboration. Those were the key competencies that they focused on. And they didn't make them up. They were a method to extend the existing competencies within each of those professions. Since then, they have gotten a great response. Much like things in healthcare and in life in general, pockets of interest sort of pop up over time. So since 2009, there has been a lot of interest in interprofessional education and collaborative practice. And how can we really inform at the academic level interprofessional education and really incorporate it into our curriculum to sustain it over time, because that's what ends up happening. You know, you'll have pockets of interest, but there's not a lot of sustainability. And that's for many reasons. So since then, the initial 2011 competencies came out as a result of that collaboration of those 6 founding fathers. So much interest in the literature has had forced them to come back together and extend the competencies and make them relevant to even more professions. And an additional, were there 6? An additional 9 professional organizations partnered with the initial 6. So now there's 15 organizations that are really committed to promoting interprofessional education. So in addition to a lot of other people, but when you look at standards across countries, the US tends to adopt the IPER core competencies, and in Canada there are some other ones that extend the core competencies to maybe 6 competencies. Today we're going to talk about roles and responsibilities, and we'll kind of see how we did that within the palliative care sim. And the roles and responsibilities really are, we need to use our knowledge of our own profession and the, other professions to appropriately assess and address the healthcare needs of the patients and populations that we serve, right? It's very simple. But it's hard to operationalize. There are many mechanisms that affect interprofessional education, like development and delivery of the education itself, the curricular content that you might focus on or prepare, and the execution of any type of course, event, activity that you provide. So here's the Pediatric Palliative Care Simulation. I'm going to go through it, and I'm going to approach it from the 8 guiding principles that we talked about the last time on how to develop and partner for delivering a good content in an interprofessional way. So the guiding principles are having a clear learning outcome or multiple learning outcomes, planned involvement of the professions, linking content to clinical experiences, making the experience interactive, building the time in for reflection, planning for formative and summative assessment, and creating sustainability. And so we might think we're doing this, but it really is a planned process. So approaching it from a roles perspective, a while back, it was in 2016, we had an idea. There was a physician that was partnering with our sim lab doing a singular interprofessional simulation based with palliative care concepts of delivering bad news in the pediatric patient population. It was a research project that ended, but the work was so valuable and the students liked it that they wanted the work to continue here at Drexel, but the funding ran out. So we had to find some partners, and we gathered a interprofessional team of people for several meetings to see if there was interest. I happened to be one of the last ones at the table, along with Pat and Scott Horowitz. And so then that's how this developed. We said, all right, sounds great. Our students like it, we're committed. We had other meetings. For the second part, to get the professions involved, we invited people from the sim lab who were nurses and staff. And we all sat at the table and generated common outcomes. And that's one of the key things when we're thinking about interprofessional education. How is the education developed? Is it the mega code that I developed for the nursing department, just overlaid on the PA program or with the medical school? That's not really the truest measure, or even it is not interprofessional education. The idea is that you need to come together to identify what the outcome should be collaboratively. Now, you might think it might be hard. Well, the hardest part is probably getting everybody at the table, or in today's world, perhaps sending email communication. But really the hardest part was narrowing down the objectives to just a couple. We wanted these grand ideas from this little simulation. We were able to narrow it down to 2 objectives, and it was relatively easy because the core competencies of interprofessional education and collaborative practice marry or parallel the professional competencies that each of our programs require for regulation and accreditation. So we narrowed it down to 2. We wanted students to learn about their roles and other professions' roles within that particular simulation. And we wanted, one of the objectives was to be able to deliver a care plan of some sort to a patient and family in distress in this time of need. And so far, we've been able to meet those objectives very easily, and it has flowed very organically. One of the key things when we think about interprofessional education is authentic learning, right? We have learners that demand excellence. They don't want their time wasted, and they want to learn real life skills that are going to directly apply to their clinical practice ultimately at the end. So linking practice or linking the activity or the educational opportunity to practice, or how it's going to be relevant in the real world, is really, really important. And so we kind of came to the idea that the delivery of bad news in a pediatric population is really relevant to all of our practices as health professions in some way. You know, you might find yourself working in an ER or in some type of shelter or something like that, where you have to deliver or support people in those times of need. And additionally, when you look at the literature, no matter what profession you're from, the identification there is that there really is a need for some type of death and dying or bad news or palliative care education within the curricula in academia. Because once they get to practice, you're expected to know what to do. And there's not an awful lot of opportunity in some of your clinical rotations to experience those things. So we thought that that particular content area was really valuable and could really be linked to practice. And then we picked a simulation. Simulation has been proven to be helpful because it allows you to experience the learning opportunity almost as if it's real life, but be able to reflect on how you performed in that activity, and then be able to say, okay, and learn from that particular activity. So you will be better in practice ultimately. Another key element is that the activity or event should be interactive. So it shouldn't be just like I'm doing to you today, standing and talking to you. We should have some type of interaction. They may ask for some class participation. I don't know how that will go. But you can't just sit side by side and learn. Now, it doesn't have to be a simulation that you do like we chose to do. I mean, a simulation is very interactive. These were 3 cases, and I'll explain them in just a minute, that really had the students going through all of the cases and experiencing them as if they were the clinicians themselves. And reflection. One of the key elements of developing any kind of educational opportunity, whether it be honestly interprofessional or uniprofessional, there should be some type of reflection built in, because during reflection is when you tend to learn and self-reflect and really identify, oh, I could have done better there, or this really went well and I'm going to adopt it as my practice. And if we don't build that time in, it often doesn't occur. So part of our reflection happens in between the scenarios that we do. There's 3 of them, and the students travel as a team throughout, and in between their individual cases, they might have a few minutes to reflect on, oh, I did that good, or I'm going to implement this next. And so I think that's pretty valuable. And of course, we have a debrief at the end, and we really come together to see what learning occurred. How this particular simulation unfolds is it's 3 cases on one day that students volunteer to participate in. So I send out an email who's interested, and we develop a bunch of students. I assign them to interprofessional teams. So there's always at least 2 different professions in a team, oftentimes 3. Now the feedback that I've gotten is that more than 3 professions within that team, the rooms are small, it's overcrowded, it doesn't feel natural. But there's often a lot of people who would like to participate in this event, and I try and have an opportunity for as many people volunteer as possible. The 3 scenarios are based on palliative care concepts, and it's delivering bad news. Primarily is the identified concept within the palliative care end-of-life world, and they deliver bad news to a teenager who has had a recurrence of her osteosarcoma that is now not curative. There's no treatment that will cure her now, and it becomes a palliative discussion on what they want to do moving forward. The other scenario is an 18-year-old chronically ill patient who has had medical attention all their life, but now has to have a relatively minor procedure, and they're going to do advanced directive counseling, or at least introduce the topic of advanced directive to someone who's chronically ill, but maybe has never thought of the end of their life in any way. And then delivering news of an infant who was born with a birth trauma and possibly taking off life support. So it's an introductory conversation. The goal is never to come out with an answer or a concrete plan. The goal is to initiate those conversations and kind of be thoughtful and respectful and care for the family unit or the patient as a whole. Once they're done, they come and they debrief as an entire group. All right. And I think there's value in this particular set of simulations in debriefing in an entire group. Everyone comes together. We watch and monitor the debriefers. We watch and monitor the situations that go on so that we can give targeted feedback if we need to, or we can say, hey, this went well, or did you think of this, and prompt some discussion. But usually it's a participant-led debrief so that they can work through their feelings, say what went well, and what they learned. And we, as faculty, learn so much from those debriefings. Some of you have participated. Claire, I think, has participated. Mary, Scott, Pat, Marianne. Yeah, it's terrific. So I put stop here, go back to the mechanisms in action, because it sounds so easy, right? So easy. It was like a sim, it's one day, it's run 4 times a year, once each quarter. So easy. No brainer. Well, I disagree. I'm going to talk about some of the mechanisms that really impact this particular simulation. And not only do the students learn about their professions and their professional roles, and what can a dance movement therapist help us with in this sort of situation, or a PA, what's their role compared to the nurse practitioner or the physician role. But we as faculty learn about everybody else's roles, including our professional staff. So I want to talk a little bit about the development and delivery and the execution of the simulation now. So in the development and delivery of the simulation, what do you think I mean by that? Anyone want to volunteer an answer? What would have to be? So using the simulation as an exemplar, what would the development be?
Planning objectives.
Planning objectives. So we talked about that. We did a really good job. It took one meeting and one live meeting, one Zoom meeting, and several iterations of Dropbox content to come to the terms with two objectives. All right, so it wasn't easy, took a long time. What else? So that was us as the curricular experts. Claire?
Training the SPs.
Training the SPs. Now, I will tell you that I was like, easy. Not easy. I learned more from the maybe hour and a half training session with the SPs for my initial iteration of this than I did like all my planning up to that point. The SPs function in the role of the patient, and when they read the exemplars and the situations, they really put themselves in those situations, and they asked the best questions. And they highlighted things for us that perhaps the lay public wouldn't understand, and it didn't seem natural and authentic in the situation. So we made changes based on their recommendations. We had to schedule SP training. We had to partner with the Sim Lab in this case, which has some nurses in the Sim Lab as well as professional staff. And the professional staff really does run that Sim Lab really nice and tightly, because everybody wants space, right? Or a time frame in the Sim Lab. And so in the beginning, I can't say that I recognized that so easily. So I couldn't understand why if I emailed them the day before or something couldn't get done, right? And I don't mean to be insensitive, but I mean, that just was the workflow. Like at the last minute, I was like, oh, I thought of this, could we? But you can't. So working with the sim experts and the technicians, I've really learned a lot. They created a process so that everyone would have fair game at having an activity in the sim lab. They would like a 16-week lead up to that particular simulation if you're organizing a new one. They have very good paperwork that you fill out that will guide you through the simulation activity, and you submit it to them. They review it, and they communicate with you to say, this might work well, this will definitely not work. We have to rearrange this. How do you vision this? How do you think this will take place? And it may or may not work. So there is a lot of pre-planning for these activities. Now, I said that this particular palliative care simulation has been in place since 2016, the way we do it now. And still, every time I'm making a tweak or an addition, and you have to allow for that lead time. And sometimes that's hard to understand on both ends of the spectrum there. I think when we think about the execution, lots of things that we don't think of, but primarily the execution of interprofessional activities, I think our biggest execution barrier could be culture, right? I said myself that I didn't understand their workflow or how long it takes things to happen. It wasn't on purpose, it just was, I just didn't think about it, but I do now, or at least I always try to improve with each activity that we run. And it does run rather smoothly, and they're terrific to work with. But I think in general, if you're thinking about incorporating any kind of interprofessional activity into your program or your course, the culture is the biggest barrier to get partners with you. The PA program and the Creative Arts Therapy program has partnered with this particular event since the beginning. They were invested, they wanted to do it. And each time I needed to partner with someone else in those programs, it worked well. It took a long time to engage the medical school to now come and participate, and I'm happy to say that they are participating. I would love the counseling and family therapy department to come and participate. You know, and so each time we think about running it, I always think about how can we plan ahead to get additional faculty and students involved in this process. And, you know, that's something that I learned over time, and particularly related to role. I would have never thought, honestly, about having a family therapist or some type of counseling therapist in these simulations or tied to one of my programs. But we ran one of the events, and one of the counseling and family therapy faculty came and participated, and he debriefed. He was fantastic. And I said, this, you know, I learned about their role and how powerful it could be. I had never thought of it. And so valuable really for ultimately the students at the end. I think about space for interprofessional education. So space for the simulation is at the sim lab. You have to request time. There's a perpetual calendar. That means that things are on there forever. And so you have to get your time in between what's going on. And honestly, that sometimes takes a lot of time. Someone mans this calendar, someone mans that calendar. It's hard to get everyone together, but we were able to get together to think about what does the PA program do at these times during the quarter or the term so that we can have PA students participate. We had to think about the med school and when are their students out on their clinical rotations or in their med student placement? Can they come or can they not come? So there's a lot of thinking and planning that has to happen. Absolutely worthwhile, but something you don't think about. And even when you prepare an activity that's not a simulation, you still have to think about those things because you have to collaborate with everybody, right? And it's certainly, to me, it's not a big barrier, but it's something that we have to think about. But it really, truly made me learn and respect the roles of everybody else. It's not just about my nursing students participating in this. I have to think about who can come and have this experience and how can I make it best for everybody. All right. So does any learning occur? Well, you know, at the beginning I was like, I'm sure they'll learn. I just want them to experience it. But I did ultimately decide to evaluate some of the activities, and I've learned over time to get a little bit better at evaluation. But what we did learn is that I asked particular questions about what's your knowledge on death, palliative care, pediatric palliative care in particular. So it was kind of about the palliative care content. And we asked about 5 questions that kind of ended up as comfort with this topic. And from the beginning, we did a pre-survey and a post-survey. And in the pre-survey to post-survey, learning occurred. And so the students overall learned from the simulation and through the simulation actually between the 3 different cases. But they're still a little uncomfortable with the content. And when I started this, I wanted people to be exposed to the content, but I wanted them to have the experience of the interprofessional activity more than I wanted them to have learning about palliative care. You know, so I was really focused on the competencies in interprofessional education as opposed to the content and being so strict on the content. So students learned and faculty learned too. So I learned that we have had about 136 students, and I'd say plus there's a few that maybe I missed in the very early stages, but about 136 students that have gone through this particular simulation, all different professions, PA, nursing, physical therapy, doctoral physical therapy students, physician students, so med students, creative arts and therapy, and dance and movement therapy within creative arts and therapy, and some of their other roles. and Savannah will tell us about those later. But few of them had opportunities in their curriculum to have additional interprofessional education opportunities. And part of the things that we advertise at Drexel is the ability to have interprofessional contacts in the academic setting. So that was basically quantitative data based on, survey data. And then some of our questions were more qualitative in nature, and we just asked for the reflections on the event. And the power is here in what the students had to say, that they'd never before spoken to a doctor, and it made them more comfortable doing that. Nice to have the team. It made it more comfortable and real to deliver bad news. And I didn't know how I could be incorporated into this team. It will help me in the future, in my future career. In the past, I usually excused myself from these type of meetings. And that's pretty powerful, right? I mean, I think when we think of ourselves as an interprofessional team, ultimately in practice, everyone should have a part in that particular plan for the patient. And I'm so much more prepared for when I will need to do this in the future. So that's it for sort of the meat and bones, the content, how we did it, how we operationalized it. And I've asked a few students from the different professions to come so that we could ask them some questions on how they experienced their event. And I think one of the main things that we as faculty need to keep in mind as we do these particular curricular changes, because there is an investment in time, money, space, and our own personal work that we think is important enough to do this stuff, but we have to practice collaboration, right? If we're going to teach collaboration. And I think that's what a very powerful message for faculty to hear, is that in order to have collaborative, practice-ready students entering the workforce, we need to collaborate as faculty and find a way to do it well and somewhat easily. I say that loosely, but if you get practice at it, we'll get better at it. So I'll ask Nicolette and Savannah just to come on up here, and we'll so that we can all see them and we're not turning our heads around, and that the camera can see them. And we have Rebecca Baldwin on the line from North Carolina at her clinical placement. We can just sit down and be casual. We don't, and I'm going to allow them to introduce themselves. And Rebecca, will do you last, okay?
Okay.
Cool. All right, we'll start here with Savannah.
I'm Savannah Stanton-Meisen. I'm a dance movement therapist.
Oh, hold on, I'm going to give you this. There you go, just so the online guys can hear.
I'm Savannah Stanton-Meisen, and I'm in the Dance Movement Therapy and Counseling Master's Program.
I'm Nicolette LaRosa, and I'm in the PA program.
All right, Rebecca.
I'm Rebecca. I'm with the PA program as well.
And joining us from North Carolina. What hospital are you at?
I'm at Central Regional Hospital. It's a behavioral medicine rotation, so it's a psychiatric hospital.
Okay, great. And Rebecca, and did you guys just be on the Friday or the Tuesday? So Rebecca had the good opportunity to participate in the simulation activity in January on a day where we had international visitors from a nursing program in South Korea actually attended the simulation and participated in the simulation. So it was pretty exciting. They learned a lot from that particular interaction. I did prepare a couple questions. They're easy. I gave it to them ahead of time. So we already know what their course of study is. I know what their course of study is. And so Nicolette, since you have the microphone, how many interprofessional educational activities have you been involved in here at Drexel?
I think this was my third one. We did one activity with Temple Pharmacy students, and then we had one with, it was physical therapy, family counseling therapy, and PA students. I think that was, those were the groups involved in that. I think that's it.
Okay, that's cool.
This was actually my first one. We have a lot of interaction within our program, but not a lot outside of our program.
Okay, and that's creative arts and therapy. Okay. And Rebecca, how about you?
I did the same 3 as Nicolette.
Okay, great. And I thought, why did you pick this particular activity? So go ahead, Savannah, you can talk first.
I'm actually currently placed at a pediatric hospital where I do work with children who could possibly be in this scenario. I personally have never had to be in a scenario where I've had to deliver bad news, so I thought it would be a beneficial experience for me to get that in a school setting where I had the ability to learn.
I chose to participate in this because I'm really interested in palliative care, critical care, those types of areas of practice. But also I'm really interested in simulation as a way to learn. Before PA school, I worked at CHOP in simulation. I thought it was awesome. So I always like to seek out simulation opportunities.
Rebecca, how about you?
So you mentioned earlier that Drexel really advertises the interprofessional learning aspect. And I kind of expect it to be more prevalent. And so whenever there is an option to do interprofessional learning, I try and jump at the opportunity. Plus, I love pediatrics, and I was really intrigued by this opportunity to give bad news about a child, which seems like the hardest thing you could possibly do. And then to be able to do that with somebody who could augment your experience and your teaching to this hypothetical patient was a really cool opportunity.
And since we're talking about like roles and responsibilities, like did you think that you were able to take away something about your own professional role and maybe the role of some of the other participants in the situation?
Yeah, I think so. I think it was really helpful. So the first experience we had, the nurse and I hadn't talked at all as a nursing student, and we kind of went in and just kind of flew by the seat of our pants. And I didn't really know what her role was. She wasn't sure what I was supposed to do. And so after that one, it was kind of, it wasn't the most fluid experience. But the second patient encounter we had, it worked much better. We kind of knew what each other would do and how we would approach a subject. And so that was a really cool thing to notice a change throughout the 2 patient encounters that we had on that day.
How about you, Savannah?
I can second that entirely. She and I were actually on the same team that day, which is interesting. So going into this, I had no idea where I would fit into this, especially because even looking at the cases, I was like, I don't really know a lot about the medicine. I've learned at the hospital, but I still could not consider myself knowing anything. So to be able to be in that space and really learning how the medicine and therapy can really work together in this kind of scenario was very, very interesting for me.
I thought that having someone with a counseling background like Savannah in my group was really great because I think in our group it was us 2 and a nurse. So the nurse and I were more focused on, treatment approaches, but there were a few times when Savannah would say, why don't we take a step back and process that for a second? So I thought that was really helpful.
Now, I think I'm going to open up to questions to you in just a minute, just so if any faculty have any questions. But I'd like to hear from your student perspective. This is largely faculty driven, and I'd like to see your thoughts on how could we incorporate students in the development, planning, and execution of interprofessional education. If you could do it, how do you think it would look? It's a big question. I didn't give that one to you.
Yeah, I was like that.
That wasn't on the email. Sorry. I just thought of it. It doesn't have to be prolific, but I'm just curious.
So I think that if maybe, so we have a year of didactic learning and then a year outside of the classroom. I think that if periodically throughout, maybe in the first week of classes, you say, hey, what other professions are you interested in learning from or with? What experiences do you think would be really hard to approach as just a PA? And then ask that every couple of months and see how the answers change so that you can say, oh, people are really wondering how to work with social workers. Could we find social worker students or could we teach more towards this so we could kind of have a handle on this is who we are curious about learning with.
That's interesting.
That is interesting. And then I wonder, how do you think, do you think the current delivery of education within all of our programs is conducted to this kind of learning? Because this was a one-off, right? You got to pick to come here. You did it on your own time. essentially. It wasn't part of any curriculum program. If you could dream it, what would it look like so that you could participate in more interprofessional work?
If I could dream it,
Dream big. It's just the
when they
world.
said Drexel taught interprofessionally, I thought it meant that on like at least weekly there was a class where there would be med students, PA students, nursing students, therapists, students, all learning from the same lecture, because we deal with so much of the same things. And so if we could be in the room together asking questions from our points of view, that it gives a progressive learning throughout however many years of class you have. But I think that would be a really cool experience to just have like a Friday afternoon lecture or whatever time, but just like an hour or two weekly where you talk about topics that everybody deals with.
Additional thoughts?
Just that I think maybe for the PA program in particular, the easiest place to integrate this would be patient communication, because we do so many SPs anyway. Maybe instead of doing them just within our own group, we could branch out more and do some with other professions.
Pediatric infant assessment. I will open it up for questions from the audience for our panel. Is there any burning questions you have for these panelists?
Can I get the microphone?
Oh, yeah, here we go.
You can be the runaround person. Thank you. This is Janet Zimmerman. I'm in nursing, and this is not so much a question as an experience that is coming back to my memory. When I was in graduate school in the 80s, I worked as a home care hospice nurse. And in the hospice practice, it's common to have team meetings and weekly team meetings for your patients. And that included physicians, nursing, social work, chaplain, and then the volunteers. And it was one of the best nursing experiences I ever had. And it didn't occur to me until I was sitting here that it was an interprofessional practice experience. And so this was really very eye-opening for me. And I think we can easily put this together: pharmacy, nursing, physical therapy. I don't know why we don't do more of it.
No, I agree. And I think one of the barriers is if you think about it, if you're trying to do this in practice, like in clinical practice, it is hard to do that in clinical practice, but certainly it's just a matter of conversation.
Can I add on to that?
Yes. Go ahead, Rebecca.
I actually thought about this. I'm so glad you brought that up because going into this phone call, I wanted to mention, so I'm at a behavioral medicine site and it's inpatient. And so we have treatment team meetings every week with a psychiatrist, psychologist, the nursing staff, a social worker, and possibly other people. But it's so cool to watch and see how different people interact with the patient. And then they also make every decision for they like make treatment team decisions together. And so it's really cool to see that compared to other sites where I've been, and it's the doctor PA is making a choice. They like occasionally consult with social worker or read a note that somebody else wrote, but like it's such a unidirectional decision. Whereas here it's so cool that it's so involved from a bunch of different points of view.
Claire, I'll give you the microphone so they can hear you online.
I mean, in my experience, meetings like this are for the good of the patient, right? So as our knowledge base in medicine is expanding, we need to take all of our knowledge and our experience and bring it together for the patient. So like we're all saying the same thing, but we need to come together for the patient and teach our students that, you know, come together. And this is the way it is. I do my clinical work at HUP, and, you know, you meet together and, you know, you take your experience and you put it forward to the patient because, you know, it's confusing out there. It's confusing. The medicines are confusing, you know, but the resources are out there for the patients, and we have to come together for that. You know?
Anything else? Anything from the planning perspective? They're in the back row who have had to plan with me, and Kathy. Any comments on sort of what it takes to get something like this or an interprofessional activity going? Pat's gonna. We'll do Pat first.
I'll do- This is Pat from the PA program. I think it's imperative that we do this, but I'm thinking we need to plan now for next year because it takes such a long time to have all the moons align correctly to be able to get this. And Rebecca, I love your comment about your experience in the clinical year. And wouldn't it be great if we could have that experience simulated in the didactic phase so that when students go out there, they at least understand what it's like to have a team meeting and what they need to get from the team meeting. So Rebecca, I'm gonna put you on the spot. Okay.
Great.
If we did this on a Friday afternoon, do you think students would come?
I don't think you should make it a choice.
Oh,
Great.
Savannah?
We're talking about what they're going to do with their career. They have to know how to function. Maybe Friday afternoon isn't the best. We had Monday afternoons more available. But I was trying to think about when we always had free, and I think most free time. But I think that it should be something that is required attendance to learn how to have team meetings and interact with other professions.
Savannah, you're shaking your head.
I completely agree.
Hold on.
Sorry, Maura.
Yeah. I need it. Film myself on that camera. All right, Savannah. From your program's perspective, and think about your other students as well.
Sure. So I know currently I'm one of the only people who's at a medical hospital, but I know that every single one of my classmates in both music, art, and dance all have team meetings of some sort, some part of a team that they are a part of. And I know that we would all benefit from a simulation of a team meeting or something of that sort so that we know when we're going and into our internships where we're working professionals that we have experience in this and something where we feel like we are truly doing what we're supposed to be doing instead of kind of learning as we go.
So you see that in the pre-internship phase, like first year?
Hang on, Scott, I'll come. I got a movable one. I'm like still down here.
I just asked Savannah to clarify that she sees a real benefit for that in our program, a 2-year program, in that first year, which is pre-internship, before you're out there on your own figuring it out.
Yes, I do. And I also think, I mean, it could also be beneficial for the first years as well. I think it really depends, though. But I also have a complete understanding that scheduling these kinds of things is a nightmare. But I do think if you made it mandatory and we had to show up, everybody would learn something from it. And as much as we would complain and groan about having to go in, we would still learn something.
We're going to quote Savannah and Rebecca.
Yes,
Yeah.
please do. Sure. Please do.
We're recording all.
Hey, we're the students showing up to some random discussion to talk with faculty. We're not the students that you're going to be worried about missing.
Yeah, that's good.
That's true.
That's true. We volunteered to be here.
You did.
Yeah.
You did.
Yeah.
Thoughts? Other questions? Now, and open one last question, kind of to sum it all up. If there were some things that you were very interested in learning about, like what would be your top 2 things that you feel, you guys are kind of nearing the end of your programs. So think about what do you think was missing? Like what would you like to see in a professional environment? What might you value? Maybe one thing.
From this experience?
Not from this experience, but just in general. Like what would you like to see interprofessionally? Like what kind of experience would you like to be involved in? Just how we generate our ideas. Anything maybe that you struggled so far in clinical practice that you didn't feel you got in the didactic area that might have been better to practice interprofessionally before you went into practice?
This really isn't a new idea, but just kind of reiterating, I think it would be a really great idea to have a practice team meeting because like Rebecca, on my psych rotation, we had team meetings every day and I kind of went into that really not knowing what was going on. So I think that would be something that would be really great. And I never really thought about doing something like that before, but if you could incorporate that into our didactic year somehow, I think that would be awesome.
And kind of going along with that, I think giving the students the ability to kind of discuss what our roles are and where we feel we fit in those kinds of scenarios. Because yes, everybody is part of a team, but I know I hold a different role than she does. Like, I know that for a fact. So kind of having an understanding of what does she think she does? What do I think I do? And how can we work together and how can we relate to each other? Same with the nursing staff. I would love to know like what better connections we can make in our clinical practice moving forward, and building those team meeting experiences can be a way to do that too.
I think as far as what kind of things have I felt unprepared for, I think the palliative care is a really big topic that we should have at least one time saying, hey, you're probably going to die. Here's what we think you should do. Or like, let's talk about this. Because that's a topic I have never talked about that with anybody. And I've never thought about talking that with, because you don't want to think about that. And so making yourself have this conversation with someone is really important before you do it in real life, to a really sick patient. And I think, I had another thing. One thing that we had, I was at a rotation at Hahnemann Hospital for internal medicine, and one of the things that was really puzzling to me was what to do with homeless patients. And so that's another subject that I'm very not aware about what to do. And so I think maybe an interprofessional discussion with therapists, social work, that kind of a group, like, what do you do? What are the resources? And having people from their different backgrounds saying, like, this is how we can help this person. These are government funded things that patients gets their med from here, or like something like that. Does that make sense?
Yes, it does.
Absolutely. Or immigrants, you know.
Yeah.
I can second that entirely. I feel like we get a lot of information about what to do with children, like in abuse cases or suspected abuse, but we don't know what to do with those kinds of adult situations.
I mean, Philadelphia is an immigrant sanctuary city. Excuse me. Philadelphia is an, I'm not sure of the right terminology. Sanctuary city. And, you know, inner city, how do we deal with those? You know, how do we work together interdisciplinarily to help these people? And what are the conversations? How do we even bring that up? Thank you.
Thank you. Well, any other thoughts for our panelists or comments? Well, that brings us to the end of our discussion today. And I thank you all for coming in person and virtually. Are there any questions from the virtual audience? That's one thing I didn't ask.
There was one question that came up regarding, I think it was when we were talking about different types of ideas that we wanted to incorporate. Utilize hospital-based huddles in the clinical environment. She said, Barbara wrote, I sent an email with more communication with SBAR.
Okay.
This month's Journal of IP&E discusses the use of iSBAR and the IDEAL tool. It's about safety as students with clinical rotations utilize the adjuncts.
Okay, perfect. And I'll provide them for people to download, I guess, those resources. But someone made a comment online that we should use more huddle type interactions, and that's actually very prevalent in the world of safety in the clinical setting at the moment. Huddling every 4 hours to flow plan and identify sick patients. It actually has been very helpful in my own clinical practice. We've used various different tools, but the huddle seems to work better at identifying. It's a interprofessional huddle that we come together and talk about who's the sickest and who might need an intervention. It really does work well.
I just had another thought. If there was an event of a mass casualty, does it filter down to the regular patient care about how to handle, how do you prioritize who gets moved? I keep thinking of the storm that they had in New Orleans. Sandy? Was it Sandy? No, it wasn't Sandy. Katrina. And, a hospital was actually completely cut off and isolated. And right. And, how would we work together interdisciplinarily to something that we think will never happen, but it certainly could.
Yes, it has. All right, well, thank you all for attending and giving up your time to come and do this and listen to the valuable information I hope you got from here.
Thanks.
Thank you.
Our next event is Developing Shared Language Communication Skills in Interprofessional Education, Tuesday, April 30th. Registration will open soon. And then May 28th, write together a primer on publication. And next week for Tuesday topic, we have LGBTQ&A, pronouns, policy, and practice right here in room 1043. Same bad time, same bad channel. Thank you.
Thank you.
Good job, guys.